Dear students and colleagues, the topic presentation today is liver cirrhosis. And liver cirrhosis is a terminal stage of chronic liver disease. And liver cirrhosis is established by the process of necrosis and regeneration of hepatocytes, resulting in fibrosis and capillarization of the hepatic sinusoids. Liver cirrhosis always present with the deformation of liver structure and their configuration with a portal hypertension, and decreased hepatic parenchyma, disturbance of blood flow leads to portosystemic shunt and portal hypertension, and all manifestation of portal hypertension as ascites, as varices in esophageal, in rectum, hepatic encephalopathy, and another complication. Causes of cirrhosis, it's any liver disease like non-alcoholic fatty liver disease, alcoholic fatty liver disease, autoimmune hepatitis, cholestatic liver disease, autoimmune origin like primary sclerosing cholangitis, primary biliary cirrhosis. It can be inherited metabolic disorder like Wilson disease, chemochromatosis, alpha-1 antitrypsin deficiency. It can be vascular diseases like Budd-Chiari syndrome and viral infections. Plus, it may be drug-induced hepatitis and another type of hepatitis which present with inflammation of liver and increasing level of LT and AST as a marker of inflammation. The main clinical features patient with liver cirrhosis, it's a fatigue, it can be low-grade fever, unknown origin, it can be fata hepaticus, sarcopenia, Jordan's, any bleeding due to coagulopathy, it's edema and ascites due to portal hypertension and low level of albumin. It can be cardiac dysfunction and cardiomyopathy, especially in patients with alcoholic liver cirrhosis. In examination patient, we can see palmar erythema, spider nevi, leukonychia. Patient can have endocrine disorders and decreased libido, testicular atrophy, gynecomastia, amenorrhea in women. Can be diabetes and decreased tolerance to glucose. Patient can have osteoporosis, bacterial infections, and other complications. For diagnosing liver cirrhosis, we have several steps, and first line diagnosing is of course screening test like a history of disease. We ask everything about patient anamnesis and genetics and using drugs and other factors which can lead to liver cirrhosis. Of course, important physical examination, and the main symptom we can visualize in patient I told before. For screening, we do biochemical analysis, and we are interested in level of bilirubin, LT, AST, level of prothrombin and albumin because they are synthesized in liver, and ultrasonography of liver, spleen is important for first line diagnosing. The next step is more deep examination patient. We are wondering about complete blood count and level of hemoglobin, platelets, leukocyte, coagulation test. We do cholesterol, triglyceride, glucose test for patient. The next Step 4 examination patient is a special laboratory testing for confirming diagnosis and etiology of hepatitis and cirrhosis. For all patients, we do test for viral hepatitis B, C, D. We check for autoimmune tests like anti-nuclear antibodies, anti-mitochondrial antibodies, SLE, perinuclear anti-cytoplasmatic antibodies. It's all tests for autoimmune hepatitis, for cholestatic liver diseases patient. The next is immunoglobulins and level of ferritin, iron, transferrin saturation, level of copper and excretion of copper with urine. And the next stage, next level of examination patient is molecular and invasive studies like liver biopsy, like MRCP, and it's a genetic test for metabolic disorders. We do for chemochromatosis, for Wilson disease, for alpha-1 antitrypsin deficiency. Necessary to note that increasing level of AST and LT is a marker of hepatocellular injury patient and marker of inflammation. Increased LT and AST occur in patient with hepatitis, inflammation. Increasing alkaline phosphatase and gamma glutamyl transferase are the marker for cholestasis and cholestatic liver diseases. Patient who has increasing anti-mitochondrial antibody can have the primary biliary cirrhosis. Patient with elevated anti-nuclear cytoplasmic antibodies can have the primary sclerosing cholangitis. There are many methods for measuring elasticity of liver, and there are several stages of fibrosis from F1 to F4 stage of fibrosis, which leads to liver cirrhosis. And we can measure liver stiffness in ultrasonography examination, and in very informative is MR elastography of liver. At this slide you can see different result of MR elastography of liver patient with chronic hepatitis C before treatment, top row, and after treatment, bottom row. And the stiffness patient initially was 6.2 kilopascal, and after treatment stiffness of liver decrease up to 2.6 kilopascal. At this slide you can see different stages of liver disease from steatosis, top row, non-alcohol steatohepatitis, middle row, and patient who has stage of liver cirrhosis, bottom row, as a final stage non-alcohol fatty liver disease. And you see how to increase stiffness of liver from 2.2 kilopascal up to 6.4 kilopascal in liver cirrhosis. For classification liver cirrhosis, in practice we use Child-Pugh classification. This scale includes 5 indexes like stage of encephalopathy, ascites, level of bilirubin, albumin, and international normalization ratio. According to these points we calculate stage of patient, and you can see at this slide that patient with liver cirrhosis stage C has not good life prognosis and life expectancy. Yes, is 1 up to 3 years. Very short, very high mortality patient with liver cirrhosis classes C. But necessary to note that patient who hospitalized initially at hospital can has more high class severity because has more high level of bilirubin, low level of albumin, more progressed stage of encephalopathy, and when patient discharged from hospital, his class of severity can be decreased, for example from C initially to B when discharged from hospital. Patient with the liver cirrhosis has a lot complication, and here you can see a list of such complications like gastrointestinal bleeding, ascites, acute kidney injury, hepatic encephalopathy, thrombosis, sarcopenia, muscle cramp, thrombocytopenia, itching, hepatopulmonary syndrome, portopulmonary hypertension, vitamin D deficiency, decreased albumin, and it's not all list of complications has patient with liver cirrhosis. About ascites, one of the very common complications in cirrhosis, and there are several grades of ascites. Grade 1 when patient has a mild ascites which can be visualized just in ultrasonography. Grade 2 when patient has a moderate ascites and you can visualize in examination patient, and in grade 3 patient has massive tense ascites, and sometimes patient need paracentesis, evacuation of ascitic fluid. What's necessary to do if patient has ascites? For all patients we should analyze ascitic fluid. For it we need do ascites puncture, and we should do just simple test, routine test. We measure cell count in ascitic fluid. In normal, amount of neutrophils should be less than 250 in millimeter in third grade, but if patient has cell count more than 250, we should suspect spontaneous bacterial peritonitis. Ascitic fluid we can examine in microbiological lab and do bacterial culture, and again if it's positive we should suspect spontaneous bacterial peritonitis. Very important to measure serum ascites albumin gradients, and if this is a difference between albumin in serum and albumin in ascitic fluid. If this gradient more than 1.1 gram per deciliter, we think about liver cirrhosis, or it can be in another disease like multiple liver metastasis, acute liver failure, alcoholic hepatitis, Budd-Chiari syndrome, sinusoidal obstruction syndrome, heart failure, hyperthyroidism. If serum ascites albumin gradient less than 1.1 gram per deciliter, it can be in patient with nephrotic syndrome, carcinomas peritonitis, tuberculosis peritonitis, biliary peritonitis, or pancreatitis. That's why you can see that analysis of ascitic fluid is a very important for differential diagnosis of origin of ascites and disease which can lead to accumulation fluid in peritoneal cavity. If patient has spontaneous bacterial peritonitis, such patient can have a clinical symptoms like a fever, abdominal pain. We recommend paracentesis, and we treat such patient with antibiotics quinolones. Treatment patient who has ascites includes, first of all, diet recommendation for sodium restriction for 5 up to 7 grams per day. Plus, if patient has grade 2 or 3 ascites, we recommend diuretics and we start with a spironolactone 25-50 mg per day. If spironolactone is not enough, we combine with furosemide 20-40 mg per day. Plus, we can add tolvaptan for resistant ascites and albumin infusion plus diuretics. For patient who has refractory ascites, we use paracentesis with albumin infusion. For resistant patient, we recommend surgical interventions like peritoneal venous shunt, transjugular intrahepatic portosystemic shunt, and such patient should be in list of waiting for liver transplantation. Esophageal varices is another complication of liver cirrhosis and it occurs due to portal hypertension. It's a main risk factor for gastrointestinal bleeding in patients with liver cirrhosis. Such varices can rupture and leads to severe bleeding. That's why we recommend to treat it. I tell about it later, and to prevent bleeding by sclerosing of these varices. Hepatic encephalopathy. It's a reversible spectrum of neurological symptoms ranging from minimal signs up to coma, and it connects with liver disease. Hepatic hydrothorax in most of cases are asymptomatic. Most of cases is a right side hepatic hydrothorax, and symptoms include dyspnea, cough, hypoxemia, respiratory failure. Sarcopenia, it's decreased skeletal muscle mass in patient with liver cirrhosis. It's one of the complication and one of the problem patient with liver cirrhosis, and it can lead to and progress to osteoporosis and pathological fractures. And if summarize measure for treatment patient with liver cirrhosis, first of all, we should think about pathogenetic treatment. If patient has viral hepatitis, we treat antiviral drugs. If autoimmune etiologen hepatitis, PBC, primary sclerosing cholangitis, first-line treatment should be immunosuppressant like corticosteroids, cytostatics. If patient has inherited metabolic disease, we should treat by phlebotomy, chemochromatosis, by depenicillamine, Wilson disease. Plus, of course, symptomatical treatment. If patient has varicose bleeding, we use non-selective beta blockers, we use band ligation, we use vasoconstrictors, sclerotherapy, surgical shunt if patient has acute varicose bleeding. If in case of ascites, we first of all recommend restrict natrium in diet, use diuretics, again repeat that we start with a spironolactone and after we combine with furosemide. We can use volume paracentesis. In case of acute kidney injury, we should avoid hypovolemia, we should discontinue diuretics, use albumin infusion, rehydration, and somatostatin analogs like terlipressin, noradrenaline, for patient with acute kidney injury. In case of encephalopathy, we should avoid precipitants, and we should treat bacterial infection, bleeding. We should avoid sedatives, high protein intake. Main treatment encephalopathy include lactulose and non-absorbic antibiotics like rifaximin, neomycin, metronidazole. In case of spontaneous bacterial peritonitis, we use antibiotics like levofloxacin and another from group of quinolones. Thank you for attention.